So, Vivekananda sir, shall we start with your permission?
Please.
Yes, sir.
Dr.
Yes,
Shankar
sir.
ने कह दिया तो there is no question of my permission or non-permission.
Yes. Very good evening to all, and namaskar, greetings to you on this Friday evening to World Parkinson's Disease Day. So, the Department of Geriatrics at the BLDE DU Shri Shri B Patil Medical College Hospital and Research Center and the Geriatric Society of India cordially welcomes you all. And I take it privilege to welcome all our faculty members, Dr. Manisha Arora Madam, Dr. P.S. Shankar Sir, uh, Dr. Partha Ray Sir, and Dr. Kaushik Ranjan Das, Dr. Basaraj, Chandu, and all the delegates have joined out. So we'll start with the World Parkinson's Disease Day deliberations. So we all know the importance of this disease being known for a century, but still the cure is not there. So to throw the light on this main issues, how it affects and how the person looks from this perspective, I now invite Dr. Manisha Arora Madam to continue with the presentation. Over to you, Madam. You need to unmute, Madam. Please, Manisha Madam, please unmute. Yes, Madam. Now you can.
Yes, Dr. Ambali, you have to guide me how to share my slides.
Just click the green.
How to share my slide?
Just share the green icon, Madam. Just below it is there with the arrow mark top.
Yes.
Please click it, and you have to you need to open the PPT first on the laptop, and then.
Okay. Sorry for this. I'm not tech savvy and.
You understand, but you can even present as such. No issues.
Okay. So. Can you see it now?
No.
Yes,
yeah.
Madam.
Yeah.
And now you have to make a slide screen share.
Right.
Slide show, you can make it. Yes, Madam. Perfect. Please go ahead.
Okay. Thank you, everyone, for your patience with me. And first of all, I thank the organizers for inviting me on this national symposium. And we all know that why today, we all know that it is World Parkinson's Disease Day today, and it commemorates the birthday of Dr. James Parkinson, who first identified the condition in 1817. This condition is known since centuries, but unfortunately, we do not have a definite answer to the treatment. And just going through a very, small passing reference that about 10% of adults more than 60 years are affected by Parkinson's. That is a huge number. And with overall prevalence is 7.9%. And cognitive problems are roughly in about 46%, whereas the drug-induced problems are seen in over 50%. Again, so we have to keep that in mind. And now how it impacts the life, we have to go through the cardinal symptoms that will tell us. It is known since centuries that there is a resting tremor. Imagine somebody having a resting tremor all the time. So how is that person going to perform the fine motor skills, even including writing? Or imagine bradykinesia, a person who is so active, who's been throughout active, and suddenly cannot initiate the movements, suddenly cannot initiate the gait, suddenly cannot, is slowed down in everything. He's posturally unstable, has huge risk of falls, becomes rigid. Imagine, So the motor symptoms and then even the non-motor symptoms, everything affects the daily life. And the non-motor symptoms, patient is cognitively impaired, which can range from simple forgetfulness to severe dementia. Then comorbidities like depression, anxiety, they can be associated. Patient has sleep disturbances, which can range from early awakening to nightmares to RBDs. And this not only affects the patient, but also the partner. Then autonomic dysfunction. Like initially, patient may not have urinary incontinence. Patient is taking longer time to reach the toilets, but then with time, autonomic dysfunction sets in, and all these features are developed. So imagine a person having, it may be an early stage or it may be the late stage. So if somebody is having tremors, there'll be difficulty eating, dressing, grooming. There is fine motor skills will be affected, even writing, even signature in the bank. All these things are affected. Bradykinesia, person is slowed down throughout. Every task is time consuming now. It affects the mobility. There is increased risk of falls. So, and patient becoming rigid. In the long run, it can cause severe muscle pains. It reduces the flexibility. Posture is different. So this is all the physical impact person has. And obviously, all this has a lot of impact on the daily life. Somebody, imagine a lady who's got 2 3 children to look after, and himself or herself is not able to do the daily chores. There is a delay in meal preparation, and cannot, the most important, the driving abilities are lost. There are safety issues even if they try to do so. So that limits individuals independence, and whenever there is loss of autonomy, it definitely affects the mental health. So the impact is not only on the physical health, but also goes over to mental health. And with bradykinesia, rigidity, patients have difficulty getting out. They need help. Even in the late stages, they cannot do their own work, and they need all the time some carer. And even dressing, grooming, everything becomes difficult. And the postural imbalance, the routine things, walking on the uneven surface, going on the stairs, everything becomes extremely difficult. So not only this has physical impact, but also the emotional and social impact. Patient is embarrassed. Imagine a youngish patient or in late 50s, going for a conference or going for a, meeting, feels very self-conscious. Even they withdraw socially. And they all this leads to mental health issues. Patient doesn't want to interact socially. And obviously, if they're still in job, there is it affects their job, it affects their career. There is difficulty in completing the jobs assigned to them, and this ultimately leads to frustration, anxiety. So there are day-to-day challenges. See, family also supports, but if family is not understanding, there can be relationship problems with the family and friends also. So all this, has a huge impact mentally, emotionally, socially, and this ultimately has a long-term consequences, which leads to the increased risk of falls. And one fall, one fracture can really keep them on the bed for longer times. Mobility is reduced, they are dependent, socially isolated, and then mental health issues. I think these are the challenges one has to keep in mind while treating the patient. And it is not just that. And there is a talk also on that it is not just the patient who suffers, it is the carer. There's a lot of pressures on the carer's mind, and there is a lot of pressure they go through, and there are a lot of challenges they go through.
Why?
It is very important once we know that
Patient तो वही कितने?
once we know that patient, can go through all this, I think keeping all this in mind makes us more humble, more empathy towards the patients, taking care of the carers, and dealing with every aspect becomes very auspicious, very important. And today, it is more so on this day, we need to raise the awareness that so that the disease is picked up in the early stage and not delayed. So with the time, I keep it short, and I hand over to Dr. Ambali.
Thank you so much, madam, for that brief introduction. And you have covered almost every aspect of the disease that affects not only the person, but also the family and social issues. So very nicely covered the real issues that as a geriatrician faces, a physician faces while we manage patients with Parkinsonism. Thank you so much, madam. Now I invite Dr. Shankar Patil, sir, for his deliberation on historical background. And over to you, sir.
Yes, thank you. Just a minute. So I have been asked to speak on the historical aspect. Yes. So can you identify George Bush, the former president of the United States? Muhammad Ali, Paul. So all these three persons, one being a politician, another being a sportsman, third is the spiritual head. The only common thing is all of them suffer from Parkinson's disease. Can you identify this? Everyone will say, I will identify. And they say it's a Parkinson, but they are all wrong. No portrait of Parkinson is known. A photograph, sometimes identified as an image of him, is of the dentist of the same name, and he died because Parkinson died before the invention of photography. All our people have just created.
Sir, just a minute. Please make your slideshow proper.
Slideshow ಆಗ್ತಾ ಇಲ್ಲ. One minute.
Sir, please make it
Sir,
slideshow.
please mute your mic.
Sure.
वेबिनार मध्ये क्लिनिकचा फोटो आला.
Are you able to
end
see?
पे डॉक्टर योलेकर
Sir,
का
now it
mic
is seen,
mute
sir,
कर दो.
perfectly. Now it is seen. Please carry
Now
on.
it is.
Yes, sir.
So
Please.
I was remembering about these three individuals, and I showed this portrait, and everyone will say he is Parkinson, but they are wrong. The reason is no portrait of Parkinson is known. A photograph, sometimes identified, which I have shown as an image of him, is of a dentist of the same name, and Parkinson died before the invention of the photography. So there is no photograph is available. So James Parkinson, exactly 217 years ago, the London surgeon apothecary James Parkinson, he published a 66-page long booklet entitled An Essay on the Shaking Palsy, which contains a first clear clinical description of the shaking palsy or paralysis agitans, which we now refer to as the Parkinson's disease. So this is a small book which was published in 1817, Essay on the Shaking Palsy. So the original description, what he gave, even today we have not changed. What did he say? Involuntary tremulous motion with a lessened muscular power in parts, not in action, and even when supported, with a propensity to bend the trunk forward and to pass from a walking to a running pace, and the senses and intellects being uninjured. That's the original description which he gave in 1817. So in mid 1800s, Jean Martin Charcot was a very well-known neurologist of the France, and he was particularly influential in refining and expanding this early description and in disseminating the information internationally about the Parkinson's disease. He separated Parkinson's disease from multiple sclerosis and other disorders which are characterized by tremor, and he recognized the cases that later would likely to be classified among the Parkinsonism plus syndromes. So the value of the essay was not fully recognized during his lifetime. Nobody recognized today, which we are telling Parkinson's disease on his birthday. Nobody gave any importance to that. He was successively or concomitantly a virulent political activist, taking active interest in politics, a popular medical writer, a scholarly medical contributor, a highly appreciated parish doctor, a prominent amateur chemist, and a renowned paleontologist. So it is that branch of the geology that brought Parkinson's fame during his lifetime. He was an insatiable collector of fossils, minerals, and shells that came to form the core of the museum that is set out at his home in Shoreditch, England. So because of that, he was known, very well known, not as a person who would give a description of the Parkinson's disease. So this we are now telling these manifestations which he described in 1817. So he brought out three important books, and them are the Introduction to the Study of the Fossil and Organic Remains. He published in even before that one. Organic Remains of the Former World. Outlines of Ontology, that's the study of the fossil. So he brought out these three important books. So Organic Remains of the Former World, he in three different volumes from 1804 to 1811, he brought out as a treatise that rapidly became a standard paleontology textbook. Parkinson was a founder member of the Geological Society of London, and in recognition of his contribution to the nascent field of paleontology, his name was given to many fossils, particularly ammonites, Nautilus parkinsoni. He is referred as a paleontologist as he used to be referred to after his death for such a vast and multifaceted contribution to the natural science and medicine. So he spent his most productive year in writing about the history of Earth, geological state of England, and the principles of horticulturology, that is the study of the fossils. His monumental, illustrated, organic remains of a former world was at that time viewed as his most important and influential work. No one, certainly not Parkinson himself, could have predicted that 2 centuries after his death, he would be remembered not for these large accomplishments, but for a much narrower one, that is the neurological disease. So he took over his father's medical practice, worked as a practicing physician in Hoxton all his life. He was best known for disseminating the medical information and for his geological work. In the time when only the rich could afford to consult medical doctors, he worked hard to make a basic information about the medical care available to anyone who could read. He gained fame as an author of a large number of medical articles, pamphlets, and books. He wrote about topics like care and feeding of children, how to recognize and treat rabies and epilepsy, how to treat intestinal worms, the nutritional importance of breastfeeding, the dangers of quack medicines, the health benefits of personal hygiene, and the values of inoculation in preventing smallpox. His medical advice was brought together in 1799 in his medical magnum opus, a 2-volume encyclopedia referred as Medical Admonitions. His ability to observe carefully and to draw fresh influences from what he observed, his work on what he called the shaking palsy originated not in observing his own patients, but in noticing the strangely tortured movements of 3 elderly men, strangers to him and to each other, as they moved awkwardly through the crowded streets of Oxford. He noticed that they walked hunched over, leaning forward as they shuffled. His ability to observe carefully and to draw fresh inferences from what he observed stumbled along a busy street, and he introduced himself to each of them, and asked them a series of questions. How long had they had that arm tremor? Did their arm shake like that when they were sleeping? What had triggered the condition? When had they started speaking with such difficulty, so softly and indistinctly? Was it painful to walk hunched forward like that? Did the tremors hurt? What other symptoms did they complain of? Slowness, stiffness, drooling? Did anyone else in their families share these symptoms? Were the symptoms better or worse? If they drank a pint or two of beer, did anything, fresh air, certain medicines, certain foods, certain kinds of exercise, improve or worsen their symptoms? Did they ever feel constipated? Why did they not step down, feel first as other men did? Why did their arms not swing as they walked? did they fall often? That's the question she asked. Though, through the careful observation, asking questions, and paying close attention to the answers of those three men, and later three more men who exhibited a similar range of symptoms, James Parkinson was able to draw amazingly accurate profiles of the people who suffered from shaking palsy. In 1817, when he was 62 years, James Parkinson published a pamphlet that called an essay on shaking palsy. He was surely aware of the inadequacy of the term shaking palsy, since he knew that the tremors were not always present in the 6 men he observed, and he knew that as the disease progressed, many other symptoms presented themselves. Parkinson never attached his name to the disease. In 1872, nearly half a century after his death, a French neurologist named Jean-Martin Charcot found that and read the essay and understood its importance, and he referred the disease as Les Maladies de Parkinson, and the name stuck. So never found a cure for the disease that bears his name. By observing, asking a lot of questions, and listening carefully to the answers, he showed subsequent medical researchers more precisely the nature of the disease that required the attention and that still does. It is World Parkinson Day is held each year on his birthday, 11th April. In addition to the eponymous disease of Parkinson is commemorated in the names of several fossil organisms, including the ammonite Parkinsonia parkinsoni, or a crinoid Apicaris parkinsoni, and a snail Rosterella parkinsoni, and a tree Nipa parkinsoni. They are all the names which bear his name. Thank you.
Thank you so much, sir, for that enlightenment. And a lot of issues which we are not knowing, you have brought it out today. Thank you so much for what Parkinson's was, who was he, and his life stretch. So I thank you once again. And I welcome all the members who have just joined. And we have members from Bangladesh, Kenya, United Kingdom as well. So now I invite Dr. Partha Ray, sir, to proceed with his topic, clinical features. Over to you, sir.
Right.
Dr. Partha Ray, sir, please start.
Yeah, I'm here. Can you hear me?
Yes, sir. Little loud, sir. Please speak
little louder. Right. Okay. Yeah. Am I okay? And is it in full view now? The screen?
Yes, sir. Please continue.
Excellent.
Change the slide, then we'll come to know.
Right. Okay. What about
yes,
this
sir.
one? Yeah?
Perfect,
it's
sir.
Working. Yeah.
A
Fine.
little loud, sir.
Little loud. I'm speaking through speaker phones. It's still not. Is it all right now? Yeah. Am I?
Proceed, sir. We'll see.
Yeah, we'll see. Yeah. Okay. Right. Respected members of the Geriatric Society of India, my good friend Professor Anand Ambali, my learned colleagues, speakers, and the esteemed attendants for this particular day, where we commemorate the life and times of a great human being, a great scientist, paleontologist, and of course a physician, after whom we have named this World Parkinson's Day. Now, Professor Shankar, P.S. Shankar Nadoja Shankar has actually made my job easier by introducing the essay of the shaking palsy and the historical nature of it. I would like to draw the audience's attention to the right of my slide, showing how a good physician can be multifaceted, as we all aspire to be, and at the same time can have such good ideas about preventative medicine, about good health, about having a doctrine of good health for the villagers who could have actually a bullet point stuck to their walls. This is the following works of James Parkinsonism, which have got immense health benefits as regards to first aid, as regards to common sense care, and avoiding dangerous sports. So not only is the shaking pulse is important from his perspective, but so is all the other things. Now, I won't talk about the history of when he was and where he was. I've taken out the pictures of what was purportedly James Parkinson's, because we learned that all those are of one of the two other people, the dentist and the person from Belfast who actually went on the gold tour in Australia. I would really like to draw the attention of this particular essay on the shaking palsy to all the juniors in the audience, purely because this is the first time since Professor Ambali invited me to come in and speak about James Parkinsonism that I've taken the trouble after 30 years of neurology to actually go through this book. And I felt very belittled as to how less I know after 200 years of Parkinson's disease knowledge expansion compared to what this gentleman, watching clinical observation of 6 patients over a time period from his Shoreditch house, could achieve. We have not lived up to his expectation and promise. And that's all I can say. And all we can do is that we can look forward and do better in curing and looking after all our patients, including those of Parkinson's disease, for the future. That's my take-home message from reading how much he did for us 200 years ago, and we really haven't built up on his story. Right. So I've been asked to speak for the next 7 minutes or so on Parkinson's disease clinical aspects. Now, we talked about introducing treatment for Parkinson's disease very early in the course, but you can see that the prodromal part is when the disease starts, is all in the non-motor domains. You have RBD, excessive daytime sleepiness, smell, constipation, blood pressure, erectile dysfunction, and then comes the cognitive, the anxiety, depression. And only when we hit the clinical spectrum, and you can see this particular boundary, that's when the patients come to the doctors with all the various symptoms we are so very familiar with from a third year. Now, one slide only on the Lewy bodies, because it's important that you understand how the problem actually starts somewhere in the gut neurons. And by the way, the students among us here, they'll have a copy of my entire slide set, courtesy Professor Ambali, and I've made it free to everybody here. Right, so basically the synuclein, which is the primary problem in the Parkinson's disease, actually spreads from the gastric plexuses in the gut. There's a gut brain, and also there's another group who feel it's a brain gut hypothesis, but it actually spreads slowly from bottom all the way up. And when it eventually spreads to the neocortex, then when we get the advanced Parkinson's and the dementia and all the other things. So that diagram is very important as to the spread of the disease in due course of time. So it's a clinical diagnosis. There is no test to prove Parkinson's disease. And the only test we have is the definite Parkinson's on autopsy. But this was the initial working towards it by Andy Lees, who actually found out that these pictures of James Parkinson were wrong. He brought it to light. And that this was the initial criteria. The step 1, we all know the bradykinesia needs to be there, and at least one of the rigidity tremor of that particular frequency. And then there are postural and other dysfunctions. And then we have to exclude other causes of Parkinsonism. That's where the other investigations come in. And of course, it's helpful to have at least 3 of these bullet-pointed parameters that help make the diagnosis. And as you know, that in the best movement disorder experts in Queen Square, from where all this was done, only about 85% are correct. There's still a 15% error rate among the top neurologists anywhere in the world, Delhi, Amsterdam, Delhi, or New York, or wherever. Now, the NINDS, the US counterpart, wasn't too far behind. Again, Gelb was diagnosing it. Again, they were trying to refine the diagnosis by identifying definitive Parkinson's, probable Parkinson's, and others. So basically, the tremor, rigidity, akinesia, and asymmetric onset, that's a hallmark, but not always. And then there are group B features which rule out alternative diagnosis. And there's a whole lecture there that I will recommend that I have made for the Indian Medical Association of 6 Atypical Parkinsonism, full 90-minute lectures for students, DM and MD, to understand the disease better. So the reason I'm laboring on the diagnostics is because there's a lot of features that have made the diagnosis a bit more difficult. Step one, this is Andrew Lee's, step one, then step two, and then finally step three. So we're going through the diagnostics of Parkinson's disease rather, in a very specific algorithmic way to make sure we get the diagnosis right in life. Because the mimickers and the chameleons, we'll come to that in a minute, have got a different outcome, prognosis, and treatment. And so it's very important. So moving on to the next item is the non-motor symptoms. I did show you the very first slide where it was obvious that the non-motor symptoms have a duration of 15, 20 years. And that's where these rapid eye movement, sleep behavior disorders, anosmia, depression, anxiety, autonomic dysfunction, hallucinations, and cognitive impairment precede the motor development. And that's got to be taken into concept. Right. So coming back to, again, I was giving you a high view, helicopter view, as I call it, of the disease. And then I'm now going to bore in and do the bore wells into the disease. I think this audience doesn't need reminding about the tremor, rigidity, akinesia, but postural instability is another very difficult to treat symptom which accompanies Parkinson's disease. And there are other symptoms which are part and parcel of what we get to see in daily life. But again, fatigue and dysphagia, although delayed, are again features of Parkinson's disease. Now, the non-motor symptoms I like to highlight because one of my senior colleagues from Medical College Calcutta, called Lol Rai Chaudhary, actually did the questionnaire. Like the UPDRS is actually a motoric assessment of the Parkinson's disease. But then there's a non-motor scale which he has developed, which actually covers all these various facets of the non-motor variations. And people want to know why they're having a certain disease. Many of them are not very treatable, but it's nice to be aware the reason for these conditions, which are simply the non-motor symptoms of Parkinson's disease. The evidence is there. Right. Now, the diagnosis, I'm sure my next speaker, Professor Bindu Menon, will be covering that. The PET scan is, we all used to the DAT scan. That's actually the only one which gives us definite information. The rest is basically ruling out other diseases by showing normal other studies. Now, let's talk about these chameleons. Now, chameleons basically change colors and look something like they are not. So we can often mistake Parkinson's disease for a frozen shoulder, a mood depression. So often Parkinson's patients are given a trial of antidepressants. People can have other reasons like a prostate for urinary urgency. People can have sensory pain from all different causes. So let's not overdiagnose Parkinson's at the early stages just because they have these sort of conditions. These are chameleons. So this is a repetition of what I've said before. Let's move on in the interest of time. But look out for people with early resting tremor. Their handwriting becoming micrographic. They're saying that one part of the body is not working very well. It's either stiff or achy. And they're walking in that characteristic gait Professor Shankar was talking about. And the festination, as we all know. So all these are basically early hints of Parkinson's disease, as is anosmia, as is RBDs. You wouldn't believe how many patients with motor symptoms, when you ask them, report 5 years, 7 years of their bed partners having a real trouble at night. Well, depression, anxiety, I've got lots of referrals from psychiatry colleagues, and they had subtle cogwheeling, which is very early Parkinson's. Or they have got blood pressure problems, presenting as dizziness. Fatigue is the big one that I keep looking out for because fatigue is so difficult to describe and to appreciate. And dementia, of course. Now, why are we laboring the non-motor symptoms? Because we don't have drugs as yet to catch out Parkinson's, but maybe one day we will have when we can arrest this synucleinopathy early in the process because it causes a lot of morbidity at the non-motor symptoms. And Parkinson's disease, the model is that of dopamine, but there are so many other chemicals which are equally important players in the basal ganglia circuits that we neurologists love to talk about and then forget and remind ourselves again. So some of the treatments, some of the symptoms do not respond to treatment, but I'll let Professor Bindu Menon deal with that. About the freezing of gait, doesn't go with deep brain stimulation, neither does a lot of other postural instability and the falls that take place. These are not part of the symptoms that are going to get better with levodopa or DBS or things like that. Blood pressure is another big problem, the clinical feature, orthostatic hypotension. Not many of us do lying, sitting, and then standing after 3 minutes blood pressure. But patients report to us with syncope and falls with injury, which are avoidable purely because the agents we give to patients to treat the disease often exacerbate the symptoms. Urinary symptoms, the male patient past 70 has a prostate, how to differentiate? There's a lot of comorbidity from the autonomic nervous system that takes place. Constipation, now underreported across the world, more so in India, high among females, up to 50% have constipation. How many of these are in the non-motor phase of Parkinson's disease? So there's a huge amount of assessment from constipation. We talked about REM, sleep behavior disorders. I'm out of time. Fatigue, we talked about as a symptom. We have to ask, but it could be depression and so many other things. Hallucinations, we talked about being visual hallucinations, particularly on treatment. But remember, Lewy body dementia, which is not Parkinson's, is also a high marker. So what are the red flags? Well, these are the red flags when it is not a Parkinson's disease, but something else that's masquerading or mimicking as such. So finishing off on a high note of what else it could be when it's not Parkinson's, but looking like that. Well, that's a checklist of things I keep in my head for dystonic tremor, and you can read the rest, including genetic causes like Wilson's disease, but the wrong age, I guess. And well, thank you. I'm out of time by 3 minutes. I promise to keep to time. Thank you for listening, and I wish all my Parkinson's disease patients and all patients across the world good luck and Godspeed, and best wishes from Bharat. And we look forward to looking after all our Parkinson's patients with all that we know and care for. And that would be a true honor to this man, James Parkinson, who laid the foundation stones for this disease. And it's good that it bears his name. I don't like eponymous names, but I think this one, after reading his story and his book, I'm quite honored to be able to present his story to you all on this day. Thank you very much. Bye-bye.
Thank you so much, sir, for the wonderful insight that you have shared. Thank you. And I have mentioned regarding you are very grateful that you have shared, you are willing to share your slides. And the same message has been put in the group, and we are receiving a lot of emails. So that I will do it. So thank you again for being with us and sharing your wisdom. And now I invite Dr. Bindu Menon, madam, for her presentation. So Partha sir, please stop your slide sharing.
Thank you very much. I suppose this is good enough. You can hear me. Hello.
Yes, madam.
Yes, we can.
Yeah. So I just take over from where we have had eminent speakers talking about Parkinson to investigations and management. So as we really know that Parkinson disease is purely a clinical diagnosis, and what we do is to see that we do not miss out any other treatable condition in between. So this is one picture which clearly depicts that there is a long years, almost around 15 years of a prodromal period the patient has. And if you could just see the dotted lines is a preclinical period which is absolutely not identified. And there is the reason where we could probably initiate some form of biomarker or genetic testing in these patients. The prodromal period is really very bizarre with conditions, and it is very difficult for any individual to have a diagnosis of Parkinson in that particular time period. But I am very well sure that with the advanced scientific molecular biology, everything advancing, we'll definitely have something as a biomarker in the prodromal period itself. from where we go into the manifesting stages where the symptoms have been clearly elucidated. But then we need to know that there sometimes may be an overlap of symptoms where the non-motor symptoms and the prodromal symptoms continue for a long period of time. And when the patient continues to visit the physician with all of these prodromal symptoms, which is persistent and which is increasing, but with no motor manifest Parkinson disease in that particular individual. So what we do is that we have already heard that if we really need to investigate, we really need to know that what are the other conditions that we are looking at in this particular individual. That is where we can tailor our investigations likewise. A supportive criteria of Parkinson is patient having a bradykinesia, rest, tremor, and rigidity. And there's a clear and dramatic response to dopaminergic therapy. Doesn't mean that he completely becomes all right, but then there is a measurable 30% and above improvement. The patient has got predominant cerebellar signs, and the patient has got multiple system atrophy, MSA. It could be MSA-C. If the patient has got a wheelchair-bound state within 5 years, that is very rapid progressive, keeping in mind that Parkinson disease itself is 3 types, and we can have the rapid progressive one, that is a 3rd type, which can also progress by 5 years, but then there won't be other symptoms of cerebellar signs and eye movement. Supportive diagnosis is with patients having an induced dyskinesia, which goes in favor that the patient is responsive to levodopa and hence is getting measurable dyskinesias. The patient has got supranuclear gaze palsies, downward and vertical gaze palsies, and slow downward saccade, very classical progressive supranuclear palsies. There is an absent progression over 5 years, means the patient has got tremors, the patient has got dystonic tremors, the patient is on a drug-induced, is on antipsychotics, and another notoriously used drug for from the gastroenterology is levosulpiride. The patient doesn't progress but continues to have those symptoms, then one should consider all of these essential tremor, dystonic tremor, drug-induced. The patient has a limb rest tremor, very supportive of a diagnosis of Parkinson, but has a behavioral variant frontotemporal dementia or a progressive aphasia within. That means a cortical sign within 5 years, it could be a frontotemporal dementia or a PSP. Again, very severe lower cranial nerve palsies with dysarthria, dysphagia, dysphonia. It could be MSA or PSP. Classical is an inspiratory stridor when the patient is in your outpatient and then continues to talk to you and continues to get a stridor. Is very classical. Even if you don't see the patient, examine the patient, the hearing the patient itself is very classical. Again, as mentioned, prodromal signs itself has olfactory loss. And if it is present in a patient who has an extrapyramidal syndrome, goes and points towards Parkinson. One should be wary of the low half Parkinson, where the patient has a shuffling gait and continues to have those. It could be a vascular Parkinson or a normal pressure hydrocephalus. We call it as a low half Parkinson, where above the trunk, the patient doesn't have any tremors. The patient doesn't have any of the extrapyramidal rigidity above the waist. What are the supportive criteria? An abnormal MIBG SPECT scan, where it shows a clear dopamine depletion, and alternate diagnosis of a severe autonomic failure, recurrent falls in a patient within 3 years. The patients with Parkinson also fall, but then very predominant falls very early in the course of the disease. Absence of a measurable response. So you need to have a good quantity of levodopa to be given to the patient to say that the patient has not responded. Any of the cortical sensory loss or absence of any non-motor features, just having a tremor. As I said, it could be essential tremor, dystonic tremors, or any of the antipsychotic induced extrapyramidal feature. Coming to imaging in Parkinson's, so when there is no, is there any clear-cut imaging modality that we can say that the patient has Parkinson? That may be a little hard to say, but then as we said that any of the other features which are there, we can gradually elucidate. One we can see here that is a classical sign of a normal pressure hydrocephalus, which is a treatable condition and one should not miss it. You can see the ventricular dilatation, the angle, obtuse angle, and the CSF flow in the CSF acudate, and one can do a CSF flow cytometry as well. This is a vascular Parkinson. This is a normal pressure hydrocephalus. This is a very characteristic sign which we see in patients with PSV. That is why it is very absolutely important to have a sagittal view. You can see the hummingbird. That is a midbrain atrophy in the patient, and that's the hummingbird sign. If you have it, and if the patient has a classical vertical gaze palsy and falls very early, and a lot of a rocket sign that the patient gets up and just falls backward. This is again in the patients with the morning glory sign. You can see the beautiful flower here, which we very commonly see. And that's how with the midbrain atrophy and the cerebellar pedicle, you can see that it's like a flower there. That's very characteristic of PSP. This is a hot cross bun sign, which is very classical of MSA. The pontocerebellar fibers are degenerated, and you can see that they are not visible, and that's those hot cross bun which is depicted here. If that is present in a patient in an axial MRI, and with the characteristic feature of autonomic dysfunction, and also we can see that the cerebellar folia is also atrophied. Very, very classical and which we use nowadays is this is we call as a swallowtail sign. This is a swallowtail, and this is the tail of that particular bird we can see here. And this is a classical which you should see in the patients of normal patient, where you will see that both the tails, you should see that the horns are there. And if both are there, that means that this nigrosome 1 has not degenerated, and that is normal. And if you can just visualize, you just need to keep seeing the MRIs, you can see that there is classical there, and that's a normal scan. And if you would see that this is an abnormal scan, you can see that it is not. It is, you don't need to go for a spec scan or a DAT scan. It's quite visible here that the patient has got a Parkinson disease. So some of those pictures which I have taken from the American Journal, you can see that classical, you can see there is a swallowtail sign. Here it is probably normal, you're not very clear. Here it is probably abnormal, and here you can see definitely there we don't see anything of that. So that's the absence of a swallowtail sign. Coming to the DAT scan, which is very commonly used, especially when you're not very clear that whether it is Parkinson, because there are certain telltale signs which are sort of overlaying with this. That's a DAT scan in a particular patient. You can see that there is an absence of decreased striatal DAT uptake, right more than the left. This is a patient with essential tremor, which is sometimes difficult to identify in a patient, may have an overlay of rest tremor. There is a normal DAT scan here. This is what we see. And that is a normal scan. That's a comma-shaped. That is a possible essential tremor, and that is an abnormal period shape possible. What else we can do? Do we do a genetic test? Yes, you need to do a genetic test in patients who are younger. That is an early onset Parkinson patient who has got a family history of Parkinson disease, who has got a predominant Parkinson and dystonia. Now, there is a web-based analysis where we can have all of these tests done. Why it is important? So that we can identify it as not an idiopathic Parkinson disease. Also, certain of these genetic Parkinsons are not very amenable to treatment, and we need to go, and they are also very prone to dyskinesias. As I mentioned, when we are treating, we need to know that which category of Parkinson disease this patient fall on. Is he the mild motor, where it is young, mild motor, the response is good and is slow to progress, or the intermediate, where there is some good moderate response, but it progresses, or the diffuse malignant, you see that the patient has got RBDs, they have cognitive orthostatic hypotension, severe motor, and the freezing of gait, which is mentioned by Dr. Partha, and they're extremely rapid to progress and very resistant to treatment. You need to go ahead with the intensive therapy very early. What do we have? What do we have to offer? We have so much to offer. Obviously, the therapies and the rehabilitation, restorative, maintenance, and the surgery. Now, are we treating only the motor symptoms? Yes, we are treating predominantly the motor symptoms, and the non-motor symptoms we do have, and I have just pointed out in a couple of the slides, but then you should be taking care of the non-motor symptoms, if not by medical, by non-medical measures, by holistic care of the patient. So that's the bradykinesia, hypersalivation, postural tremor, muscular rigidity. So how do we choose the initial monotherapy? Levodopa in the initial monotherapy, they all have differing efficacies. They have side effects. You need to look at the patient's age, the comorbidities. You cannot have a patient who is a very elderly, putting the patient on a large dose of levodopa. You know that the patient is going to have an orthostatic hypotension. You cannot have a patient who has got already addiction and behavioral risk factors, putting the patient on a good dopamine agonist, because the patient can have impulse control disorders with agonists. So I've just jotted out with this Augustadians. I really don't need to tell off the medications. We treat the motor symptoms with L-DOPA, non-ergot dopa agonists, that is pramipexole and ropinirole. Ergot is bromocriptine and cabergoline. MAO inhibitors, selegiline and rasagiline. Anticholinergics, trifexyanidyl and amantadine. How do we treat the non-motor symptoms? The RBD, which is very classical, where the patients in the sleep tend to enact out the dreams and might be a little injurious to their spouses itself. We give a small dose of clonazepam and can escalate. Constipation with prebiotic fibers and probiotics. Anxiety with benzodiazepines, SSRIs and cognitive CBDs. Depressions with SNRIs and SSRIs, impulse control disorder, you need to discontinue the dopa agonists. And while you're keeping the dopa agonists, especially it is more common in males, you need to tell that the patient might have any of these symptoms which are unusual, because in our Indian continent, we can't really say that they can go for gambling, but we can say that if they're unusual, kindly come back and may hint on those impulse controlled behaviors of the patient. The motor symptoms, you may start with COMT, advanced stages COMT inhibitors with L-DOPA, MAO with L-DOPA and safinamide, cognitive with acetylcholinesterase inhibitors, apathy with rivastigmine and dopa agonists, psychotic disturbances with atypical antipsychotics, and pimavanserin is now available in the market. It acts slowly, but it acts very well for the psychotic disturbances, which we used to give quetiapine now. We may gradually shift. It doesn't act very fast. Orthostatic hypotension and dose of fluorocortisone 0.1. Every patient who complains of giddiness needs to be evaluated for orthostatic hypotension in the outpatient itself, and then urinary dysfunction with anticholinergics and opioid. Some people say, should we start off L-DOPA very early in the course? Yes, it is now, we have the L-DOPA study which states that, yes, we need to start the L-DOPA very early in the course. There is no point in delaying it. We also know that once the L-DOPA has been started, there's a honeymoon period where there is a stable effect. And after a couple of years, that the patient starts having dyskinesias and they have wearing off effect. They have unsteady levels of the levodopa in the body. And then that's where we have this deep brain stimulation in these patients. If the patients, we have this 5-to-1 criteria for considering the deep brain stimulation in Parkinson disease. 5 is taking more than 5 doses of levodopa in a day. 2 is experiencing more than 2 hours of off time period. So we ask them to chart out, or experiencing more than 1 hour of troublesome dyskinesia per day. This patient is probably a candidate where you cannot keep switching from MAO, dopa agonists, increasing the levodopa, and you have to come to the deep brain stimulation in these patients. And this deep brain stimulation, how you do is that you need to have a levodopa challenge test. You need to have the patient 12 hours. You have to stop the patients from the levodopa, have him come to the outpatient. You need to give a levodopa challenge. Usually we say that we give him a 150% or 200% of the levodopa at one go. And you need to have an UPDRS score before and after. And a more than 30% improvement in the UPDRS score will justify that DBS is going to affect him. However, the patient should not have dementia, should not have clear-cut psychiatric features, should not have serious comorbidities, and there should be a family support because that needs certain monitoring. And the age should also not be very high and should have a normal psychological. We have an apomorphine subcutaneous infusion in patients who have a long-standing Parkinsonism and who are now not responsive or have got a severe wearing off, on-off phenomenon and severe dyskinesias. You can have an infusion pump, and we have patients who move around with them. They need to take care of that as well. And these are the certain indications and contraindications of the levodopa. We have something called as a focused ultrasound for tremor. It is being used in 2 to 3 centers in the country now. It is incision-free. It is minimally invasive. It is predominantly used for essential tremor, but then it is also being used for tremor-dominant Parkinson disease. It is used with an MRI-guided focused ultrasound. A small area of it is like an ablation therapy. So this is what we have, a motor symptom where we initiate the dopamine. We have a maintenance. The patient has a honeymoon period, then starts with the motor fluctuations, dyskinesias, has falls, gait period, and dysphagias, and becomes complex. And then we have the deep brain stimulation, focused ultrasound for tremors. We have the epomorphin infusion. Now we also have levodopa in the gut and certain other modalities which are being utilized, but not not available in our country, but then gradually it should be there. So the diagnosis is clinical and should be regularly reviewed, because if there's a red flag, you know that you cannot do much for the patient and you should move into a hospice care so that you ensure that the patient doesn't fall and have a fracture. Levodopa should be initiated. The patient should be counseled that he should not be overloading the tablets, because the patient gets an immediate response and he tends to take more of those. Should be counseled about the ICDs when taking dopaminergic therapy, especially the dopamine agonists, and considering referral for advanced therapies when uncontrolled motor fluctuations and dyskinesias persist. A multidisciplinary team, as has been said, there is an occupational therapy, there is a speech therapy, there's a language, cognitive therapy, and we have something called as a Parkinson Disease Movement Disorder Society, where we have weekly online classes for the patients and their caregivers to ensure the best for them. Thank you.
Thank you so much, madam, for that excellent insight on investigations and management. You have covered all the basics to the recent one, and including the investigation modalities. Thank you so much, and be with us. We may get some questions in the chat box. Thank you, madam. Thank you so much.
Thank you so
Now,
much.
I invite Dr. Basaraj Chandu to start his presentation. Dr.
Good evening.
Basaraj.
Am I audible, sir?
Yes, please.
Sir, I request the for the PowerPoint and the
It's
slide.
visible now?
Yes, sir.
Yeah, please go ahead.
So I, at the outset, I thank the Geriatric Society of India, as well as all the office bearers and the organizers for this wonderful opportunity to share my few of the professional tips regarding physiotherapy. Mainly, like as it has been already discussed by the earlier speakers and the eminent personalities, that this condition needs an multidisciplinary team, and more so over, madam just now mentioned about the movement disorders and the management, the kinesiological approach. So coming to the physiotherapy intervention, so the important step, first aspect is the examination and evaluation in Parkinson's disease. So already some of the things have been discussed, like clinical history, social history, occupational history, hand dominance, general health status, family history, medical surgical history. Now, from physiotherapy point of view, functional status is going to be a crucial one, and medications, what has been discussed as by the previous resource people. Next slide, please. Now, what are the tests and outcome measures we use among these people for the cognitive function and the physiotherapy related aspects? So, MMSE for the cognitive functions, oromotor functions is because they will have drooling of the saliva, depending on the presentation at the stage at the time of the assessment. The emotional aspects, so we can use Beck Depression Index or any other outcome measure, especially Beck Depression Index has been shown good validity and reliability for these group of patients. Then anthropometric measurements, circulatory functions, aerobic capacity and endurance, skin and integumentary system. Aerobic capacity and endurance especially is a vital part of the physiotherapeutic assessment, because we need good cardiorespiratory endurance as well as the musculoskeletal endurance. So one is a general endurance as well as musculoskeletal endurance. So both are of equal significance and importance. Skin and integumentary system, because as the movements become increasingly reduced, so with the progression of the disease, so skin care and skin health becomes a major concern, with minor wounds getting or due to bedridden stage, so bed sores and all these things. Then autonomic nervous system integrity. Next slide, please. sensory integration and sensory integrity. So whatever are the receptors and how the sensory functions are being carried out, the sensory sensations, what are they perceived, and the interpretation and the appropriate response, motor response, especially for self-protection mechanisms. Then pain perception. So pain, especially visual analog scale, VAS, or even McGill pain questionnaire, perceptual functions. So how they perceive themselves as well as the others in relation to their physical function, mental functions, social, and psychological. Then joint integrity. So joint integrity is of most importance because for any movement, for simple exercise, whatever we would advise, it requires joint integrity. So whether it is the main articulating surfaces or the peri-articular structures. So any of the structure which has been affected, articular or peri-articular, might be one of the important contributing factors for the pain, which might restrain the person from actively participating into simple exercises also, which worsens the clinical scenario. The posture. So postural control and strategies. So this being a multi-system function, and it includes the special senses, it includes the peripheral mechanisms, it includes the strategies like your ankle and foot strategies. So it is important to evaluate. Hello, am I audible?
Yes, please go ahead. Please go ahead.
Yes, sir, audible.
Yes. Then muscle performance. So muscle performance, the important dimensions of the muscle performance include the strength, that is the ability to generate the force, then the endurance. So over a period of time, the ability of the muscle to repeat a particular activity without getting unduly fatigued, and power, the rate at which the work can be performed. So whatever may be the requirement, whether it is a simple task or a bit long durated task, then motor function. So motor function is distinct from muscle performance in the sense it requires a precise motor control, learning patterns, because with the aging, which is most commonly like this condition being seen most commonly among the elderly people. So the learning patterns also vary with the age and the age group and the slowness, and gait and locomotion, like what we see short shuffling gait, the difficulty in initiating the gait or stopping once the person starts walking. So all these different patterns, uh, increase in the stance space of the gait. So all these things increase in the double support time. So all these things need to be checked into. Then the functional status. So any functional status can be outcome measures like Barthel index, CARS index. So these can be used to evaluate this functional status to know what is the level of the independence the person has. What are the simple like the ADLs, activities of daily living, which are divided into instrumental activities of daily living and the basic activities of daily living. So what is the status? So what is the level of the independence? Then the assistive devices. So what are the assistive devices that this person is using, whether it is a hearing device or is it a walker, a stick, cane, pod, and the most important is the environmental assessment, which the environment in which a person is staying can either simplify a person's living and make it easy for a person to maneuver and carry out his simple daily tasks, or a messy environment can rather complicate and make it more difficult for a Parkinson's person to negotiate with. Then systems review is we require a combined uh, coordinated functioning of all the pulmonary system, musculoskeletal, cardiac, neurological, and integumentary system, so that the person can have at least whatever minimal movements he can perform. Then specifically, we have the questionnaires, Parkinson's disease questionnaire 39 and Parkinson's disease summary index to evaluate the multiple facets of Parkinson's disease and its impact on the function and how the functionality has been influenced. Now coming to physiotherapy goals. So mainly our goal as a physiotherapist is to reduce the pain, enhance motor function. So reducing pain will come to the strategies like we can reduce the pain by using simple hot fomentation. We use transcutaneous electrical nerve stimulation or simple superficial heating modality. And again, it needs a thorough evaluation as to what is the exact source of the pain, what is the cause of the pain, so that if we understand what is the type of the pain, nature of the pain, source of the pain, so all this helps to exactly locate, means choose the most appropriate modality which is going to be most helpful for that person. Then enhance motor function. So the strategies to enhance motor function would be different, like improving the initiation of the movement, improving the motor control once the initiation has taken place, and to have a better control and to slow down and stop the motor activity as the motor task demands. Then motor improving the muscle performance. So whether it is the component of strength, endurance, or power. So we need to assess these components, and then we have to focus. Like for endurance, we can focus on improving the like increase by performing more number of repetitions rather than giving significance to strength training. Okay. Then improve postural control. So we can give multiple feedbacks like vision. There are other feedbacks in the form of the like a helmet sort of gadgets are there which are going to have sensors in them, and they will also have feedback mechanism which is going to give them an accurate auditory signal that it will anytime the person is going to deviate their head to the right, left, or extremely forward, backward. So it is going to give them sustained feedback mechanisms, and that is a signal which will tell the patient that he needs to improve his head posture, and the other mechanism for improving the trunk control and trunk posture are the tapes which can be used, the kinesio taping, and also balance. So balance, yes, we'll see discussion related to balance in the next slide. Improving the gait is visual feedback, the support, and the assistive devices in the form of walker or under supervision. Most of the physiotherapy interventions need to be performed under supervision because of the associated risk. Then fatigue management. So fatigue management, because as these people, the Parkinson's group is having an early onset of the fatigue and related to their pathological changes. So we need to see that they are not overly exercised and also they are not underperforming also. So we need to have strike out a balance between these two things. Then improving aerobic capacity. So improving aerobic capacity, we need to target either the upper limb muscles or the lower limb muscles. So especially the cardiorespiratory, large group of muscles, and including where greater volume of oxygen can be utilized by the body, taken up by the body, and utilized by the body also. Then pacing the activities also is important, and energy conservation. So conserving the energy by avoiding unnecessary activities or over activities. And overall, to maybe a slower progression is good, but promoting independence in the activities of daily living is of utmost importance. So it can be as simple as taking their own spectacles or using their doing their basic self-care activities like dressing, bathing, combing. Okay, next slide, please. Yes, so the strategies what we are going to use is mainly large number of repetitions so that they can have develop a procedural skills, environmental modifications so that the clutter can be reduced, which is going to simplify their and make the negotiation with the environment and the surroundings very easy. We have to focus on simple tasks instead of complex dual tasking. Then structured instructional practices. So due to the associated sensory, special sensory decline, we need to have instructional practices where, as physiotherapists, we give repeated instructions, whether it is verbal, whether it is visual, or in other forms. Then cues which help to support the better practice, and there are rhythmic auditory stimulation. So for this purpose, we can use like musical instruments, or some apps are already available. So this will help to improve the cadence, gait speed, and the stride length. Then multi-sensory cueing. So as we have discussed already, then uh, how these external cues are going to help the performance is they will bypass and they will diminish the internal cueing of the basal ganglia. Next slide, please. Apart from this, many a times, because of varied reasons, the Parkinson's patients might be stressed or anxious, and they may not be completely relaxed or at ease when we ask them to exercise. So, relaxation exercises, so whatever mode, whether Jacobson's technique, whether Shavasana, whether breathing exercises, so any form which is going soothing music, warm, like a bath, as simple as these things, anything which can be used to relax the person so that he can perform the exercises at ease. Then proprioceptive neuromuscular functional techniques like rhythmic initiation, diaphragmatic breathing. So breathing is one of the contact point between the psyche and the body. So diaphragmatic breathing plays a very, very significant role, because diaphragm also referred as the fifth limb of our body. So it helps in calming down the mental status also, and also enhancing the pulmonary uh, functional abilities. Then flexibility or stretching exercises. So especially for the flexor group of muscles. Now, coming to the next point is progressive overload. So this is especially for strengthening exercises. And our main target group for the strengthening exercises are the anti-gravity and extensor muscles, because they need to be very strong to overcome the flexion attitude, or the flexed attitude as the disease progresses. Then functional training, especially the bed mobility and ADL training. So bed training as well as using the bathroom. Then visual feedback using the mirror for facial exercises. So facial exercises in front of the mirror, or with along with the family members, with the near and dear ones. And then balance. So balance, most important, is the base of support. So maintaining a good, steady, stable, wide base of support, which is good enough to maintain the balance, as well as to see that the person is not going to have any minimal fluctuations or perturbations, and seeing that the line of gravity falls within the base of support to maintain the balance is of utmost importance. So balance exercises always progresses from most of the simplest things, from sitting to standing, and then from the eyes open to the eyes closed. Then gait training is, of course, with the help of the parallel bars, with the help of walker and other supportive devices, and most important is the physiotherapist supervision and the support of the near and dear ones. As orthotic device, whatever the person is using has to be taken care of, and see that the orthosis becomes a good helping tool for the patient. Then aerobic training. Yes, we can go ahead with 60 to 80% of the HR max. So, and especially here we can utilize lower lower extremity ergometry and arm ergometry. So either a lower arm using a bicycle, or an upper arm ergometry. Now, what to avoid in physiotherapy is overactivity, very long periods of inactivity, which is going to worsen the situation, and complex and multitasking activities, which is going to put a lot of stress on the compensated neuromuscular system. So this is all about the physiotherapy assessment and the intervention. I thank all the organizers and the uh, audience for patient listening and for this wonderful opportunity. Thank you.
Thank you so much, Dr. Basaraj, for your insightful discussion. Be there online. We may get some questions after some time. So we will start with the next session. I now invite Dr. Kaushik Ranjan Das, sir, to start his presentations. The more important aspect is the caregiver issues. Treating disease, making a diagnosis, treating disease is fine. But now the issue lies with the caregivers and how it should be managed. Okay, you are presenting, sir, from that side? Okay. You are sharing from your side. That's great, sir. Please go ahead.
Am I audible?
Yes, sir. Please.
Okay. At the outset, I express my gratitude to the organizers for giving me the opportunity to speak on the issue. So today's discussion is a part of Parkinson's disease management, that is caregiver issues, challenges, and solutions. So who are the geriatric caregivers or caregivers? Caregivers are the trained persons those attends a patient and helps in their daily activities such as bathing, dressing, eating, maintaining personal hygiene, medications, etc., etc. What are the types of caregivers? Caregivers are professional caregivers, independent caregivers, private caregivers, informal caregivers, voluntary caregivers. Professional, independent, private caregivers all are trained persons, and the informal caregivers are the family members, the relatives of the patient, etc. And voluntary caregivers are the member of the NGO, club, or the volunteer of a society. So, respected all, our today's discussion is caregiver. So, caregiving in our country is done especially by the family members, because more than 75% of our elderly lives with family till date. And some persons lives with spouse, and some lives alone, and some lives with relatives or others. So absolute majority person of the elderly lives with family. So therefore, family caregiving is crucial in providing quality of life to our elderly persons. And for the rest of the people, and also for the family caregiving, some professional caregivers are also required. But my main focus is on family caregivers. So before elaborate discussion, I want to focus on stages of the Parkinson's disease. There are 5 stages. Stage 1 is mild, stage 2 and 3 is mild to moderate, stage 4 and 5 is advanced with severe disability. There may be potential for confinement in bed or maybe wheelchair bound. The caregivers have role in every stages. In mild and the stage 1 and stage 2 and early stage 3, the caregivers should have a caring attitude. Actually, the person remains almost normal in this stage. If the person goes to his doctor, takes medication or takes advice, physiotherapy, etc., she can pass a normal life for years. So in that case, the caregiver's role is to collaborate with their near and dear ones, and also to observe that whether the person is going to doctors, whether he is taking medications regularly, whether he is following the advice of the physiotherapist, exercises, etc. But when the disease advances, because this is a degenerative disease and progressive in nature, and ultimately there is no cure of the disease till date. So as the disease advances, the caregiver's responsibility increases. They have many things to do. In that case, so during the mild cases, caring attitude, and as the disease advances, safety concern comes, and finally, only comfort is to be provided by the caregiver to the Parkinson's disease patient. So, what are the caregiver issues and challenges? In my deliberation, I describe this. I divide these issues into issues in general and issues particular for the Parkinson's disease. For a caregiver, the issues in general are knowledge about knowledge and skills. A caregiver may have insufficient knowledge and skills to understand and manage patients' physical, cognitive, emotional, and behavioral problems, and they have little knowledge about the disease, may have no knowledge about the disease. That is why the patients, caregivers want to know about the patient. They need to be informed about the diagnosis, treatment, complications, predicted recovery of a disease or the disease of Parkinson's disease. So this should be done by the doctor concerned, or maybe done by the trained professionals. Professionals that also they can take information from organizations working for the cause of Parkinson's disease. As the disease progresses, and complication arises, then caregivers also requires how to manage the complications. They have to know the assurance about the patient's safety, in how to prevent fall, how to maintain the medications, how to provide adequate nutrition, and also the behavioral, instrumental, physical, psychological problems how to manage them. The caregivers need to be open and honest communication about their role and abilities of a patient while offering hope. Another issue comes into play, this choice of working pattern. The family caregivers may be working person. They have to work for earning, so they have to attend their duties. That is why they should have a routine for doing extensive services during the weekends. And the family caregivers can divide working hours between themselves. Caregiver stress and strain. During long-term caregiving, the caregiver may want to know about the long-term caregiving. Their reports, due to long-term caregiving, the reports physical and emotional strain. This comes. They are worried about themselves and the care recipients also. They feel extreme tiredness and therefore losing self to caregiving, and also burnout may be the issue. During the course of caregiving, the caregiving givers experience difficulty in performing family rituals, visiting family friends, attending religious services, participating in social events or classes, and going out for enjoyment. Caregivers report a loss of friends because of inadequate social contact with these friends. They may feel abandoned and want their other family member to offer assistance rather than waiting to be asked to assist them. These are the challenges. So what are the issues particular for the Parkinson's disease patients? Number one, the managing physical and cognitive symptoms. What are they? The motor symptoms, those have been elaborated by our respected previous speakers. So this management of the motor symptoms, what we see during our practice, we see that this caregiver has come out their patient for a walk, and suddenly there is fluctuations of the motor symptoms, and the patient has fallen on the ground and injury occurred. So if the caregiver knows this fluctuation, this fluctuation symptoms, then he or she may remain aware or alert to prevent fall. So this fluctuation of the motor symptoms may be due to the disease itself or may be due to medicine taken by the patient. Then comes cognitive impairment and non-motor symptoms. There are many symptoms of cognitive impairment. There may be thinking disability, memory disturbance, executive functional disturbance. There may be language disturbance and other non-motor symptoms that may be depression, anxiety. There may be dementia, agitation, then in bladder problems, the gastrointestinal problems, all may come in the course of the disease. This caregiver should know how to manage these symptoms. I want to cite one example that there is rigidity in case of a Parkinson's patient. So the caregiver should be aware during lifting the patient, shifting the patient, changing the position, because if they do not handle the patient correctly, there may be muscle rupture, there may be tendon rupture, there may be also fracture. So this should be, there should be the knowledge on the part of the caregiver to manage them. So emotional and psychological impact, caregiver stress and burden, anxiety, depression, sleep disturbance may be there. Sleep disturbance may cause sleep disturbance of the caregiver also. Social isolation, this occurs. Financial stress. This is the long continued disease, the terminal disease. There is expenses increases for the medications, for other things also. There is unpredictability and progression of the disease I have discussed earlier. The communication and relationship challenges also there due to the language problem and due to other things. This maintaining as the disease progresses, maintaining relationship becomes difficult on the part of the caregiver. The caregiver may suffer from stigma and social isolation also. Here are some assistant devices, only just to have a look. This is lesser cane, walker without wheel. This is staff transfer bench. This is shower chair. This is a bracelet because the speech of a person, Parkinson's disease person, is incomprehensible. Then this bracelet may work. The other devices, these are weighted buttonade, zipper puller, magnetic buttons, this trimmer sensor utensils, then scoop plates, rocker knives, etc. These are the assistive utensils with oversized and angle handles. So in providing or in conferring better quality of life, these caregivers can take help of these assisting devices. These assisting devices, many more are there. We can search online, or one thing, there are societies working for the cause of Parkinson's diseases. These caregivers can contact them and can learn about the how to use, how to get them. So what are the probable solutions? So prevent the burnout, to prevent tiredness, caregivers should keep time for themselves. Family caregivers may divide working hours according to their preference. I have described earlier. They should learn as much as they can about their loved one's disease. And let their loved one participate in the activities of a caregiver. To consult their loved one about their family affairs. This is also a part about his end-of-life care, her end-of-life care, about managing finances, financial matters, banking matters, wills, properties, etc. And one important thing, to set realistic goals for themselves and their loved ones. And they should not put their life on hold. life should continue. They should try to remain as normal as they can. They should have someone they can talk to. This someone may be the physician, maybe the professional caregivers, maybe the society is working for the cause of Parkinson's disease round the clock. Another thing, they should take help of the respite care center to take some respite. They can keep their loved ones to a respite care center. There is homely environment, and there will be medication facilities also. And after some recovery of themselves, they will bring back their loved one to home. And also to take respite by handing over care to a professional or voluntary caregivers for some time within the home. So thank you very much for patience hearing. Thank you. Over to Dr. Anand.
Thank you so much, sir, for covering all the features that a caregiver should know and how best they can help the loved ones to lead a good quality of life. So before, sir, please stop sharing your slide.
Yes.
And before we put in the chairpersons in action, I just like to share some snippets. Yes. So we just had, we should know that one of the famous farmer, he made a Parkinson tulip. He grew one specific tulip which has a red and white leaves, and he unfortunately developed Parkinson's disease, and he honored the tulip name as Dr. James Parkinson tulip, just to honor the disease which was discovered by Parkinson, which he was suffering. So this is how the people show gratitude to their disease also. And I think Madam was already telling, according to research article, but the brain changes that lead to Parkinson start to occur about 6 years before the symptom appears. So which is true with all the chronic diseases that we come across in our life. And we all must know that the government of India in its 2016 Gazette has brought Right of Persons with Disabilities Act. Now it has considered Parkinson's as a disability, and they are eligible for all the benefits another disabled person gets. And in Karnataka, a few years back, the government had brought a scheme that the caregivers of patients with multiple sclerosis, muscular dystrophy, and Parkinson's disease will be paid 1,000 rupees a monthly allowance, but it still remained in the paper, not yet in the reality. So this is just a small video where we tried, most of you must have seen that how the technology has helped many people to lead quality of life. And these designs are there in the patented and in the market just to control the tremors and improve the quality of life of the people living with it. So this is how the things are changing and they're coming for the health benefit, as Kaushik sir also mentioned, that technology and the various devices are available to assist. The only thing we should be make aware for the caregivers, and of course they should also be affordable for all of them. So just this is a program which was to create academic interest, scientific evidence, as well as the awareness amongst all the doctors present here. And this is just a simple instrument that gyroscope. So it immediately stops the tremors. And like that, there are many technological things are coming to the market, and it goes on and on. This is how it helps. So there are recently a guideline has been brought. I will share this guideline in the group of Geriatric Society of India. There's hospital safety guidelines by the Parkinson's Foundation, that how the older persons with Parkinson's should be managed in a hospital as well. So also the WHO has brought on Parkinson's disease. This is available online free of cost to download. So now over to the chairpersons, Dr. Shailaja Rao, madam. Madam, are you there? Her father is not well. He is admitted in one hospital in Raipur. I think she must have gone. So Dr. Prabhakaran, sir? Dr. Prabhakaran, sir, from Kerala, are you there? So fine. Moderators, Dr. Tejaswini and Dr. Varathi, would like to say something so
Yes,
that
sir.
we will wind up.
Yeah, I thank and congratulate Dr. Ambali sir for organizing this very comprehensive and crisp session on Parkinson's. Actually, I didn't know that it could be finished within 1 hour. So, which included all the essential knowledge we need to know to diagnose and treat this demoralizing disease. I just had one small question for Dr. Bindu Menon, if she is online.
Yeah, she is there.
Okay, ma'am, just your experience on this apomorphine infusion, just wanted to know.
Ma'am, thank you for the question. We have a couple of patients on apomorphine infusion. So those patients are the ones who had limited response to increasing doses of levodopa, carbidopa, and had dyskinesias on the medications, and were not on age where we could initiate a deep brain stimulation for them. Having said that, there is a little cumbersome actually. The patient caregiver changing the pump, having a person by the side, as we had our last speaking out, the caregiver needs to take care of the pump infusion. So the patient does have a good response, but then if the family support is not there, any of those DBS, apomorphine tablets, pumps, injections might a little bit be a little hassle to carry on with for the patient. But then it's an alternative, as we say that unless there is a family support, this can't be initiated.
Okay.
Thank you.
Thank you so much.
Hello. Hello.
Yes, sir, please.
Can I add something here?
Yes, sir, please.
Okay. I'm Professor Amir Rahman from Bangladesh. So regarding the apomorphine, in our country there is a pain also, because it is just when there is a off period, you can use the pain as a as a insulin, like insulin pain like. So if you off, then you can push the insulins. But this apomorphine pump is good, but it is continuous. But it needs just whenever you want, you can take this apomorphine, and you can working as 2 hours, because during lecture period you may be off. So that time you can use this pain. There's a D-mind pain in the from the abroad. We can use this in our country also. Thank you.
That's great news, sir. And thanks for adding up. Yes, Tejasan. So now I invite Dr. Vivek Khanda, sir, Secretary, Geriatric Society of India, to give his concluding remarks.
A very good evening to all again, and congratulations, Dr. Ambali, for arranging such a detailed exposition on the subject, which took us from the history to its current management, covering all aspects. And listening to all the experts, though the disease was described more than 200 years back, our understanding of the process and the management is still a work in progress. We have achieved much, but I think it's still a work in progress, with issues of access and availability of the modalities for its management as far as the community at large is concerned. The end point of any management is a good quality of life, which is a huge challenge for these patients and their families because of the social and societal withdrawal, which impacts the social functioning and relationships of the patient with the society and of the caregivers with the patient and society, included. There is a lot of stigmatization due to lack of awareness regarding the disease. And Dr. Das very rightly mentioned that there is need to even train the caregivers, be it the family, be it the extended family, or be it the community caregivers in the private and the community domain included. The patients, carrying out activities of daily living are a challenge both for the patient and for the family caregivers, wherever families are involved. And the caregiver too face issues which were very nicely elucidated by Dr. Das. So all in all, I think we still have a long way to go. We have achieved much, but
any place we can have healthy food.
Pardon? Somebody wants to say something? No. Okay.
No, sir. Please.
Yeah. So as far as the community goes, the challenge is to create community groups which can help the patient and the caregivers alike. Making the services for the diagnosis, for the treatment, for the investigation, whatever modalities are available, make them available and accessible to people at large, because they are still, I think, focused or concentrated in a very few centers in the larger cities. They're not available to people per se. I could be, if I'm wrong, I would love to be corrected. And I think that is the challenge all the societies of professionals, healthcare professionals, they need to work on this aspect so that the services and the awareness is disseminated to society at large. Thank you.
Thank you so much, sir. I invite Dr. Karthik to propose vote of thanks.
Thank you, Ambali sir. Good evening, everyone. It is of great honor and privilege for me to propose vote of thanks on this event of organizing National Symposium on Parkinson disease. Firstly, I would like to express my gratitude to Dr. P. A. Shankar sir, Professor Emeritus, Dr. Manisha Arora ma'am, Dr. Partare sir, Dr. Bindu Menon ma'am, Dr. Basavaraj Chandu sir, Dr. Kaushik Ranjan Das sir, and Dr. Vivek Handa sir for giving a wonderful talk and sharing their valuable insights. I would also like to thank Dr. Atul Kulshreshtha sir, Dr. Shailaja Rao ma'am, and Dr. Prabhakaran sir, chairpersons of this session, for gracing this event. I would also like to thank Dr. Tejaswini ma'am, Dr. Vijayapura sir for moderating this event. And I would also like to express heartfelt gratitude to our beloved HOD, Dr. Anand P. Ambali sir, South Zone Coordinator, Geriatric Society of India, for being the coordinator of this wonderful session. I would also like to thank Geriatric Society of India and Department of Geriatrics, BLDE DU Shri B. Patil Medical College Hospital Research Center, Vijayapura, for giving this amazing opportunity and for organizing this Zoom meeting. Once again, I would like to thank each and every one of you present here for being an amazing audience. Thank you so much.
Thank you. Thank you, sir. Kaushik sir, anything you want to say? Thank you so much.
Thank you.
Wish you all a very
Thank
good
you,
night.
Anand, and a very good night to all of you.
Thank you.
Very
Good night, sir.
good.
Good night.
Namaskar. Thank you.
Good night, sir.
Thank you, sir.
Good night, Ajita madam.
Namaskar.
Good night. Good night.
Good
Mukund
night,
sir,
everyone.
namaskar.
Okay, very good night.
Namaskar. Kokatnur sir, namaskar.
Namaskar, sir. Good night, sir.
Good night. Good night, Dr.
Good night.
Ajita ma'am.
Good night to all.
Good night, sir. Good night, Mukund sir.
Good night.
Thank you, sir. Thank you.